Good afternoon, dear colleagues. Thank you for coming to our event. And I would like to introduce my friend and my colleague, Dr. Ali, and my co-worker. We worked together for 2 years. He's an excellent cardiologist, and he's well known with his down-to-earth attitude, and he's very cooperative with his colleagues, and very loved by his patients. This afternoon, he will talking to us about heart failure with preserved ejection fraction, which is a very important topic, important to all physicians, to family medicine, to internal medicine, and of course to cardiologists. He will talk to us about the updated guidelines for HFpEF. Thank you, Dr. Ali.
Thank you, Dr. Iman. Thanks for the audience. Welcome, Dr. Abdullah. Thank you. We will speak today about the heart failure with preserved ejection fraction. This is a new topic, and many patients suffer this disease. Next. So the heart failure with preserved ejection fraction is now becoming common disease, and half of patients with heart failure having heart failure with preserved ejection fraction, meaning that the ejection fraction is more than 50%. Next, please.
Can you also close the door, please? The door should be closed. It's too noisy.
The prevalence is much now because of the common diseases and the increasing age and the prevalence of obesity, and also the hypertension. Many risk factors can lead to the HFpEF. So the pathophysiology of this disease is what's called hypertrophy of the muscle of the heart. We have thickening and shortening of the muscle of the heart. The normal LV filling is achieved by ventricular suction, the early active component of diastole, which is generated by intraventricular pressure gradient and mitral annular longitudinal excursion, and the early diastolic LV untwisting with the elastic recoil of the muscle. So if this muscle is becoming stiff and thickened, it will relax in an abnormal way, and will happen the increase in LV and diastolic pressure. Each of these four elements is impaired in patients with HFpEF, especially with stress or exercise. So filling becomes dependent on the high left atrial pressure, and the atrial kick of the atrium is responsible for most of the LV filling. So also the HFpEF, we must consider there is two things: symptoms, signs, and investigations. Symptoms and signs of heart failure caused by structural and or functional abnormality of the heart is the main etiology. Then we have also a lab test that can diagnose this case, including the BNP and the markers for the heart like troponin and other markers. So body mass index also is important on those patients. We must also measure the obesity factor. So the patient will come with dyspnea. So we must also differentiate the different reasons of dyspnea, if it is cardiac, pulmonary, or other sources. We have cardiomyopathy, coronary artery disease, valve disease, pericardial disease, and arrhythmias. We have also the pulmonary diseases, including obstructive lung disease and restrictive and pleural disease and pulmonary embolism. We have also the other sources who must be excluding anemia, neuromuscular disease, deconditioning, and of course anxiety. The common symptoms are breathlessness, dyspnea, exercise intolerance, fatigue, and swelling of extremities. The signs, one of the most important we must diagnose is atrial fibrillation, because this is one of the major criteria to diagnose HFpEF. Elevated pro-BNP and BNP, jugular distension, hepatojugular reflux, and pulmonary crepitations with third and fourth, sometimes fourth heart sound. This is one of the scores we can use in the clinic to diagnose HFpEF. This is the most commonly used one, which including 2H, the heavy weight body mass index more than 30 kg per meter, square meter, and if the patient is on two antihypertensive or more. So every factor of those will take a number, and the number will be counted. At the end, we will see if the patient have HFpEF or no. Atrial fibrillation is one of the major criteria. It has 3 points. Pulmonary hypertension also, if the pulmonary systolic pressure is more than 35 millimeter mercury on Doppler echo. Age also is a factor if more than 60 years. And finally, the filling pressure in the Doppler echo, if the E over E prime more than 9, it's also taking 1 point. So if the patient have 6 points or more, this is highly diagnostic for HFpEF. This is the same score for HFpEF diagnosis, and at the end down we can see it's called the incidence of HFpEF, or the how much percent this patient have HFpEF. It will be, if the patient have 6 points, it will be more than 90% that this patient have HFpEF. This is another score also, but it's more in depth for the echo and labs and biomarkers. So the E over E prime, one of the diagnostic tools, we have more than 15 millimeter mercury is a major criteria. Sorry, more than 15 is a major criteria. If the TR velocity or the systolic pulmonary pressure more than 35 is a major criteria. Also, the left ventricular mass index, if it is approaching a certain level, it will be a major criteria. Some biomarkers like the PNP and proBNP, if reaching certain levels above 220 for the proBNP or above 80 for BNP in sinus rhythm, will be a major criteria. Also, in atrial fibrillation, the PNP and proBNP will have a different levels so as to be included as a major criteria. So more than 5 points in this score is considered diagnostic for HFpEF. The treatment, unlike the HFrEF or reduced ejection fraction, we have multiple therapies that cut the mortality and the hospitalization, while in HFpEF we have trials that have morbidity only, and some very little trials have mortality benefit. We have trials on the ACE inhibitor, ARBs, and MRA and ARNI show no significant reduction in heart failure hospitalization or mortality, except maybe some of the sacubitril valsartan criteria for the patient who has a benefit from hospitalization. So this is the previous trials done on the different medications for treating HFpEF. We can see most of all of them are neutral. Sildenafil was studied, spironolactone, irbesartan, candesartan, digoxin, perindopril, and nebivolol. All these medicines studied with no benefit. So in recent years, several global phase 3 trials have identified a promising therapy for HFpEF, focusing on symptom improvement and the NIHA class and the quality of life, reduction in heart failure hospitalization, and effect on mortality. The most important one is SGLT2 inhibitors, which have dramatically changed the symptoms for those patients. This is now must be first medicine to be given to those patients. 2 landmark trials demonstrated significant benefit in HFpEF patients with or without diabetes by reducing the heart failure hospitalization and improving symptoms without clear mortality reduction. Current guideline now recommend SGLT2 inhibitors for all patients with HFpEF to improve the outcome. So this is the first trial, the Imperial Reserve trial, which shows a reduction in the by 29% in heart failure hospitalization with no significant difference in cardiovascular mortality. The second trial is DELIVER for dapagliflozin, and this trial also show a benefit in the all-cause mortality and show no difference in the all-cause mortality, but it show a reduction for the morbidity. So another new medicine, finerenone, we just heard about it in the previous lecture. Finerenone, also a new medicine. It's used usually for diabetic patients who have impaired renal function to delay the progression of the renal disease. It's one of the MRA, and it's used for those patients. It's causing sometimes hyperkalemia. It's non-steroidal selective MRA. This study, the Finerats HF, studied in the patient with ejection fraction more than 40%. There were 6,000 patients. After 32 months, finerenone meets its primary endpoint, showing 16% reduction in the total heart failure events, first and repeat hospitalization, plus cardiovascular death compared to placebo. Cardiovascular mortality only was not statistically significant. The expected side effect was hyperkalemia, as I said. GLP-1 agonist, also semaglutide. It was used for obesity-related HFpEF. So it always coexisting with obesity is the HFpEF. So in 2023, the STEP HFpEF trial tested semaglutide. It was 2.4 milligram weekly, the higher dose, and versus placebo. It was a small study, 529 patients with ejection fraction more than 45% and obesity. At 52 weeks, semaglutide produced remarkable improvements in symptoms and functional capacity. This is the semaglutide study. So in adult patient with heart failure with preserved ejection fraction, once weekly treatment was associated with greater reduction in heart failure related symptoms and physical limitations and greater weight loss versus placebo over 52 weeks. This is another trial for the tirzepatide, which is also a new medicine, GLP-1, and it was a smaller study also, 364 patients. So the treatment also, as we can see, there is significant p-value 0.026 reduction in the heart failure morbidity. So worsening heart failure events was less in the tirzepatide. Also, so we need a larger studies for those two medicines, GLP-1, so as to directly put them in the guidelines. In summary, after years of negative trials, the landscape for heart failure with preserved ejection fraction therapy is now rapidly evolving. SGLT2 inhibitor, empagliflozin and dapagliflozin, have proven to improve symptoms and reduce heart failure hospitalization in HFpEF. MRA are re-emerging as beneficial. Finerenone has shown outcome improvement and ongoing research with the spironolactone also. There is another trial, may reinforce its role. ARNI, the sacubitril valsartan, can be used and have a good effect on certain population, usually the females or those with mid-range ejection fraction. Novel therapies targeting comorbidities like semaglutide for obese patient can, as we said, substantially enhance quality of life. So this is guidelines for treatment or algorithm for treatment for us. We can use the SGLT2 first, and those with always don't forget the diuretics as the first line in acute cases, because this is what's called the fast effect and fast response for individuals with fluid retention. Loop diuretics can be used. For women, we can use the MRA, and also ejection fraction in the mid-range, we can use the MRA. Also, the ARNI sacubitril pulsar can be used for and have a better effect on women with ejection fraction less than 57%. ARPs can be used if ARNI cannot be used. So this is expert consensus on management of HFpEF in the 2023 ACC guidelines. The diagnosis needs to be multidisciplinary. There is scoring system. Natriuretic peptide must be used in diagnosis. EF 50 to 50% is considered abnormal in women. Non-cardiac disease can mimic HFpEF. Also, SGLT inhibitor must be used. GLP-1 rule, pulmonary artery pressure monitoring, ARNI have been proven to be beneficial in HFpEF patient with ejection fraction less than 60 and women. So in the MENA region also, we must consider exercise, control obesity, hypertension, diabetes, and cost considerations. Thank you very much.
Thank you very much, Dr. Ali, for your excellent presentation. We have time for one question.
So the biggest challenge when it comes to HFpEF is diagnosis, isn't it? Diagnosis of HFpEF is the biggest challenge.
Yeah.
So we have this score. Again, if you look at C statistics of these scores, it's like flipping of a coin. You know, it's not that accurate. So I mean, it's nice to start a GLP-2 inhibitor because, you know, you're not going to lose anything. But starting other medications like ARNI or, you know, thinking, you know, to improve the heart failure symptoms, I don't know. We need to first diagnose it. What do you think of that? I mean, HFpEF diagnosis. Any remedies? You have any tricks?
Yeah, diagnosis is challenging for these cases actually because there is common symptoms for those people, dyspnea and exercise intolerance. Some patients have only what's called the exercise intolerance is due to non-fitness, obese people, and so we sometimes we must have a score for that reason, so as a BNP level or a pulmonary pressure level or echo Doppler criteria. All these are what's called objective tools we can depend on to diagnose.
Who is using a scores? HFpEF is 2 scores. 1, 2, 3. The rest doing what? Just based on the symptoms and clinical and biomarkers.
And biomarkers. Yeah. I would like to stress on the importance of proBNP, and you will be surprised how many of the patients who present to you with shortness of breath and they are hypertensive, and you will find out that their proBNP is in the thousands. And the other important point is the echo finding. So doing an echo and assessing the mitral inflow by tissue Doppler and by regular Doppler, it would make really a difference in diagnosing your patient.
I think a good hand like you, Doctora, you're able, but most of us like Mickey Mouse of echo, you know, not getting. Dr. Hani.
Thank you, Doctor. Very, very nice case. Very nice presentation. I think this is a very common phenotype. We are currently doing a randomized clinical study at Imperial Diabetes Center. 32% of patients who have very little symptoms have an abnormal NT-proBNP. It's a very accurate assessment. However, the test that you have to use a different cutoff point. For the outpatient setting, it's 125, and it's not age dependent. Less than 125, likelihood of heart failure is very low. More than 125 is really very strong. So I think this is the point. All of the labs are using different cutoff points, 300, 600, 700. But I think this is an absolute cutoff point. And I think if you add that with, you know, as you mentioned, very detailed echo. The other thing is the phenotype itself. The obese patient with metabolic syndrome is very likely to have this kind of phenotype. So using even a partial score, not even a complete score, if you recognize that patient, plus and dyspnea is very, very common, this is going to help us find a lot more patients.
So heart sometimes fails, not because it's weak, it's because racing for too long. Dr. Ahmed Munir, you will enlighten us about this case, I think, or title, which is, I think, very, very intriguing, you know, because we miss these people. And sometimes we don't know if this is primary cardiomyopathy or something else. Dr. Ahmed Munir, the co-director of this meeting. Shukran, Doctor.
Thank you very much, Dr. Ali, for the presentation.
عنده knee problem مسكين فسامحوه يعني.
Okay, so a very quick case, just only 2 minutes talk, but we will have like 13 minutes of discussion. So tachycardia induced cardiomyopathy, okay. I'm sure that all cardiologists are aware about this term. We are not seeing it very frequently. I think the electrophysiologists maybe they see it a little bit more than us, but I have seen it, and I'm sure all of you have seen it. So our case is very interesting case. He's a 50 years old male, okay, who presented to one of the clinics with fever, sore throat, vomiting several times, following by collapse at home after 2 days of intense exercise. You know, I have some patients who comes to me and said, I'm going to the Ironman contest, or I have hiking like 2,000 meter up, climbing the mountain. So past medical history is hypertensive and dyslipidemic on amlodipine and atorvastatin, 50 years old, young. He was preparing for an Ironman triathlon actually, okay, and was exercising over 10 hours every week for the last 2 months, which included heavy lifting at the gym and cardio exercise. He started to feel unwell just 2 days prior to the hospital admission. He went there, he went to his GP, who treated him like a normal flu. He gave him antibiotics, his vitals were fine, temperature a little bit high, 37.1, weight 68, saturation was 96. So clinical examination was unremarkable, apart from mild tonsillar erythema. So he was treated as a normal common cold. But when the ECG was done, it showed an atrial fibrillation with ventricular rate above 110, with a right bundle branch block morphology. So labs was fine, apart from the troponin was a little bit high, okay? And we had a CT pulmonary angio because it was being, actually I saw this patient after that in my clinic for second opinion, and he did a CT, and this was the picture of the, how can I go back? It showed that right ventricular arrangement with right ventricle to left ventricle ratio around 1:1, okay, which we see it sometimes in athlete people. There is a strain in the right side. And I remember, I don't know if you are fans of football or not, 10 years back came to my clinic a professional football who was coming from, I'm not going to mention name, he was coming from Cote d'Ivoire, and he was playing in a leading team in Dubai. So he got millions of contract to go to one club in Abu Dhabi. So in Dubai, they give him a report that he's unfit. He actually the best player of the UAE Premier League that year. Okay. They didn't tell me all of this. They just came to me one day and they said, can we do fitness for him? But there is no insurance. We pay cash. We did everything. He was fine. Then he got the fitness, and then later on, I knew from the newspaper that there was a problem with the report. The doctor thought that because of the echo and dilated right ventricle that there is something wrong. No. Usually athlete people, they have a little bit of dilated right ventricle. It's part of the athlete heart. Anyway, so we start him in IV amiodarone and full anticoagulation, and he's reverted to normal sinus resp. My question now, we did an echo, okay? Ejection fraction looks compromised. So now we're going to open the discussion. So do you think that this is a typical form of tachycardia-induced cardiomyopathy, or the intense exercise that he have done, okay, could have led him into atrial fibrillation? That's why he have the new onset of left ventricular dysfunction. So is there any clue what shall we do next? What shall we do?
Anyone wants to take this?
Yes, yes.
لا.
Yeah, Bish. عشان امشي ركبتي بس.
Any kind of supplements, especially inject.
He doesn't take injectables, but he take L-carnitine pre-workout, but he doesn't take any growth hormone or any injections. Okay, I asked him about that. So one of the most common things which is being used here in the gyms in UAE, two things. The pre-workout, something called whey protein or whey protein, something like that. It is full of something called green tea extract. So if you look into the leaflet, you will find that.
So green tea extract.
Yes.
For what?
Caffeine,
Losing
caffeine.
weight or what?
No, to give the boost.
Boost. Okay.
To give the
It's
boost.
full of caffeine,
Yeah.
basically. The
Exactly.
pre-workout is full of caffeine.
So one of these this whey protein concentration, it is equal to as if you are drink 25 cup of green tea. So it is very dangerous. Okay, some supplements are caffeine free or something like that, but you will never believe. So these people, when they go to the gym, you know that some trainee, they come, they take from him this that he wants to be strong and he wants to do like that, but at the end this is very harmful things. Okay, we have a patient with dilated cardiomyopathy because of growth hormones and testosterone and so many injections. Dr. Ayman.
Thank you. Actually, I would like to confirm in this point. In the gym, usually practice, there is huge supplement of pre-workout, post-workout, increase endurance. So it is very important in this kind of patient to clarify the history of supplement, because they use what you can call C4, whatever, some substance not have any license anywhere. And I faced same like this problem in Kuwait before, and but here is little bit tricky because the other guy was clear history of supplement, but here there is many substances used not off label. It is not guaranteed to be healthy at any
Okay,
level.
so either it's from the supplements that he's taking. He was taking two things, as I said. He was taking L-carnitine and pre-workout, which I'm sure that it's full of caffeine, or it's a severe form of athlete heart, and he exert his heart to a level, or it is a tachycardia induced cardiomyopathy. He never had any checkup before, so we don't know. So, Dr. Mu'taz, what do you think? Do you think that if he had an atrial fibrillation for quite some time with this LV dysfunction, he will not be able to do this, these 10 hours of intense exercise?
Tachycardia-induced cardiomyopathy, it happened very, very rapidly. So I've seen it in people like within 24 hours developing atrial fibrillation, they go into severe LV impairment. Typically, it happens over a period of time, normally a few months at a time. So if you're suggesting that he may have had the AF for a longer period of time, it is possible, but there's no way of telling that.
Yeah.
It is less likely that he just developed it, went into tachycardia-induced cardiomyopathy straight away within a few hours of having it, but it is possible. As colleagues have suggested, supplements and things that we don't know that we tested, you don't know what's their effects on the heart. Intense exercise in itself can sometimes lead to a form of kind of stress-induced cardiomyopathy.
Okay.
We did the study in the local area when I was training, and they basically just collected troponins and proBNP at the end of marathons, and pretty much all of the athletes have raised levels. So you could technically have a form of stress-induced cardiomyopathy, which is
so if it's diagnosed as atrial fibrillation, frequent and paroxysmal.
So if this is going to be tachycardia-induced cardiomyopathy, you'll have to wait until he gets the next episode of AF. And if he gets the next episode of AF and he goes into heart failure again, then that confirms your diagnosis.
Okay. Shall we advise him to stop exercise?
Moderate exercise, not stop. Moderate exercise, which is often a very difficult thing in these patients because they value their exercise a lot and they know that they will lose a lot of their fitness. But the problem with exercise, it has a J curve kind of effect on cardiovascular events and mortality and things like that. So as you exercise, your cardiovascular risk goes down until you reach a certain level. But if you exercise more, the risk would increase.
So it's better
beyond
not
that.
to exercise.
Exactly. I know this is your motto. I know this is the way you're thinking.
Dr. Hani. Dr. Hani.
I think the challenge is this is a competitive athlete, right? You just said he got paid 8 million dirhams to come and join. So yeah, he's a competitive athlete. Right?
Yes.
So he
Yeah,
will-
triathlon, yes.
So he will essentially lose his job and his contract forever.
Okay.
So
He's not a footballer. He's going to Ironman triathlon, which I don't know, but from the name, it looks.
it looks like there's a lot of running involved.
Yeah.
We can't run, me and you.
Okay. Because of our needs
Because of the
only.
knee, exactly.
But when we get fine, we will run, no problem. We're always running every day in the clinic.
So it's a tough question. I think, I agree with Batas. There's a lot of risk here, but what are you going to tell the patient? There's a very famous athlete called Reggie Lewis who was allowed to play by the Mass General electrophysiologist. He arrested on the field. He literally had a cardiac arrest on the field. So these public events are very dangerous when you have sports athletes. There's a lot of different things you have to go into the differential diagnosis.
Okay. Joseph? You want to comment? No. على مهلك يا باشا على مهلك
Okay, so the intense exercise per se for long hours, like 10 hours per day for a couple of months, is already a reason why he would have tachycardia-induced cardiomyopathy. It can come as episodes of paroxysmal AFib or even inappropriate sinus tachycardia or PVCs, like induced cardiomyopathy. We never know if he had like long-term frequent PVCs that can cause eventually to tachycardia-induced cardiomyopathy in addition to the AF. So it could be only some other form of arrhythmia, not only the AF. Sometimes patients have silent AF, especially this patient who is athletic, is doing a lot of exercise, he's taking a lot of pre-workout diet like caffeine. I mean, this C4 and all the things in the market contains a lot of caffeine, and it's called pre-workout. So I'm sure that it's all many factors, but what I'm 100% sure of, it cannot happen in 1 or 2 days. The modeling of the LV, it takes some time, like at least a few days, like a week or a couple of weeks. The heart failure can occur at once, like if a patient has acute myocardial infarction, for example. But to have a dilated cardiomyopathy, either it is the LV or the RV is dilated, it takes some time. Exactly what's happening also with the pulmonary embolism and the RV dilatation, all the things. So I'm sure that he might be having some like silent arrhythmia due to the long-term effect of the tachycardia, whether it was AFib or something in addition to the AF, like atrial tachycardia, PVCs. Eventually, he had these symptoms at the end. So, but I'm sure that it's reversible if he stops this, and I don't know if he stopped this, whatever he's taking, and this intense exercise, because.
So, Ahmed,
Thank
for
you.
sake of time, can we?
Yeah,
go?
I'm done.
You've done?
I'm done.
It's still difficult. You keep us with still puzzled. I still don't know what to do with these patients. So it's a matter of exclusion. You have to exclude everything to come with this diagnosis. I mean, is there any other way we can early diagnosis of these people?
I'm not sure. Maybe
We have
Dr.
to exclude
Ahmad,
many things.
Dr. Ahmad will also answer. I mean, cardiac MRI would help here to differentiate between different types. Cardiac.
Thank you. Actually, this would be my topic today. For example, the role of cardiac MRI in detection of arrhythmogenic diseases as a spectrum and the differential diagnosis. And as we know now, the term arrhythmogenic is now is expanding massively to include diseases that predispose for scarring of the myocardium and predispose for arrhythmia other than the genetic. So if we are talking only about arrhythmogenic, that we know it is a genetic background, but now they are also trying, and there are, from imaging and clinical aspect, they are trying to include diseases like sarcoidosis, amyloidosis, even myocarditis as precursors for fibrous changes in the myocardium, which can act like an arrhythmogenic focus. So all this spectrum falls under the MRI capacity for detection and diagnosis and early prediction.
Doctora, since can I ask the co-chairman here? She's a woman. I see if that's something common in female. You've seen any cases in female?
No, mostly men. And I would like to stress on the importance. Thank you, Dr. Ahmed, for raising this issue of taking careful history of your patient and ask him about the pre-workout, because many of them, they consider it as it's not a medication, it's not a drug, it's just a pre-workout. And you will be surprised how many of your patients are using this regularly, and it really causes palpitation. If it does not reach to the level of AF or cardiomyopathy, it causes for many of them palpitations and insomnia because of the high dose of caffeine. And I would like to ask our colleagues for their opinion how to treat such a patient. And would he a candidate for ablation? Would you consider it as paroxysmal AF? Is he a candidate for ablation? And I would like to start him on anti-failure, ARNI, beta blockers, and so on, together with even after reversing him, reversion to sinus rhythm.
So we'll leave that kind of questions for you to think about it, because we are running. Thank you very much.
Just
Dr.
one question. Just
Yes,
one question.
yalla,
One question. Ashwagandha and matcha. Did any of you see any patients who got palpitation because of ashwagandha and matcha, or just only me?
Yes. You are right.
Ashwagandha.
Sure.
You will not take it more than 3 months.
Take it all over again because of this, because it can cause palpitations, tachycardia, ashwagandha specific.
So there are many things to discuss. Lots of supplements.
So next
going on.
session, ashwagandha in coronary artery disease.
Right, yeah. So now we have with Hikmah Symposium and Dr. Ahmed Munir,
Yeah.
the power. What? The power your patients desire. What was that power?
شفت بقى هوريها لك.
الأشياء السرية هذه. يلا قول.